Good evening, everyone. I'm Dr. Kaladhar, head of the Department of Critical Care from Yashoda Hospitals, Malakpet. Welcome to our Tuesday Masterclass webinar series. So, from the Department of Critical Care Medicine, Yashoda Hospitals, in association with Hyderabad IDCCM chapter, we bring forth these sessions very regularly where the students are involved presenting the live cases and the expert panelists guide them. So where in-depth learning and clinical relevance and updated information is shared very regularly. So most of the students have given their feedback that they are very useful and they go through these series webinars regularly, especially before exams, which had been very helpful. Recently discussed with some of the students, they were sharing their feedback. So for this, today's webinar topic is Preeclampsia and Eclampsia. For this, I invite our expert panelist, Dr. Sharmili Sinha, madam. She is the Senior Consultant Critical Care Medicine from Kola Hospitals, Bhubaneswar. Welcome you, madam, on board.
Thank you, Swash.
And I welcome Dr. Manokanth Madapu. He is Senior Consultant Critical Care and Anesthesia from Ferandez Hospitals, Hyderabad. I welcome you, Dr. Manokanth.
Thank you, Kaladhar. Thank you for having me here.
He is my friend and my classmate during anesthesia from Usmania. So I welcome Dr. Vishnu and Dr. Shabana, our IDCCM Resident from Yashoda Hospitals, Malakpet. They are going to present the Preeclampsia and Eclampsia today. So it's a straightforward case. We'll proceed. Dr. Vishnu and Shabana, please go through.
Good evening, ma'am. Good evening, sir.
Good evening, ma'am.
Yes. Myself, Dr. Vishnu Vardhan. Today we are going to present a case of Preeclampsia, Eclampsia.
Dr. Vishnu, make it as a slide total, like full slide, no?
Slideshow.
Yes, sir.
Slide.
Okay, sir.
It's not coming. Still slideshow is not in play. Can you try again?
So just press the slideshow above. So you can see home, insert, design, transitions, animation, slideshow in the top line.
Slideshow is in progress, it is showing. Probably you can stop sharing and again start sharing.
Okay.
Now is it okay, sir? Yeah, we can see the slides.
Yeah, probably we can go ahead. Yeah, okay.
Hello. This 31-year female resident of Nalgonda, housewife by occupation, primary gravida with
The slides are not going forward.
Okay, and you have to make it full slide. Actually, it's
Yeah, it's not slideshow. Yeah, I think you just stop the screen share and again select the proper one while sharing the screen. Yeah, it's good now.
It's 31-year female resident of Nalgonda, housewife by occupation, primary gravida with 31 weeks, 1 day period of gestational age, presented to ER with chief complaints of history of seizures 2 episodes 1 day back and altered sensorium. Coming to history of presenting illness, patient was apparently normal 4 days back when she developed headache, diffuse, lasted for 5 hours associated with nausea and blurred vision, followed by 1 episode of vomiting, for which she consulted local hospital and was told to have high BP recordings. and she was started on a labetalol 100 mg tablet oral and steroids for 2 days. Later, after 2 days, in view of persistent headache, patient reviewed and recorded to have high blood pressure and was taken up for emergency LSCS at around 6 p.m. 6 January at 1:30 a.m., patient developed frothing from the mouth with tongue bite followed by confusion for around 10 minutes. On the same day at 1:30 a.m., patient developed a tonic-clonic activity of all 4 limbs, uprolling of eyes and deviation of head towards left. Frothy discharge from mouth with the confusion lasted for 30 minutes. She received injection magnesium sulfate and was referred here in view of persistent seizures.
So just pause here for a minute. Go to the first slide. So do you know what was the blood pressure? What was the initial blood pressure when she came in? And do you have any?
No documents were available.
Did you get that documentation?
No documents were available, sir. Only they orally they have given the history.
Haven't got any reports, sir. No
Okay. So basically, you're trying to understand what was the initial blood pressure. So I see that the labetalol dosing is only 100 mg PD, and she was sent home after giving an injection of steroid.
Yes.
So while but the patient actually came with complaints of diffuse headache, that is and nausea and blurring of vision. So this was all before the first time when she went to her local hospital, right?
Yes, sir.
Yes, sir.
Yes.
Okay. So do you see so what is your inference with this situation?
It's a case of
It is already 31 weeks plus 1 day, right?
yes, sir.
And she goes to a hospital with a history of headache, diffuse headache, nausea, vomiting, 1 episode of vomiting, and high blood pressure, right?
Yes.
Is there a red flag there?
Yes, sir.
Yes. Headache, blurring of vision is a
Okay.
with a high blood pressure.
So this is something to keep in mind about how things could have gone differently. Okay, next I proceed.
Past history, patient there's no history of diabetic, hypertension, seizure disorders, and hypothyroidism. Patient had a regular antenatal visits.
But you said that there were no records available.
Yes, ma'am.
It was told by the attenders, ma'am. Actually, they didn't get any reports. Okay.
Personal history, diet, mixed diet, appetite adequate, bowel and bladder regular, sleep disturbed since 5 days because of headache. Marital history, married life 8 years, non-consanguineous, conceived under IVF treatment, and family history, nil significant. On arrival to ER, patient was drowsy but arousable, GCS E3 V4 M6 with the bilateral pupils 2 mm reacting to light. Airway is patent, breathing SpO2 91% on room air, 99% with a 2 liters O2, nasal bronchs, and respiratory rate around 20 per minute. Circulation, blood pressure 150/90 and heart rate 110 beats per minute regular. Disability, patient is drowsy, arousable. Deep turn-on reflexes 3+. Exposure, temperature 98 degrees Fahrenheit. With the left hand IV cannula 20 gauge in situ with IV fluid NS on flow containing magnesium sulfate 4 grams. The ABG is pH 7.5, PCO2 25, PO2 61, and bicarbonate 22.7, lactate 1.6.
So if you pause on this slide, I'm just trying to understand where was the magnesium sulfate? You mentioned magnesium sulfate 4 grams IV on flow. So basically they started 4 grams in Nalgonda and then they sent them to Yashoda, right?
Yes, sir.
Okay. And this ABG was done in the ER?
Yes, sir.
Yes.
Here.
So what is your opinion on this ABG?
Respiratory alkalosis.
With hypoxemias or 61 oxygen PO2, sir. This is with oxygen or without oxygen? This PO2 of 61 millimeters mercury.
Without.
Okay. And what about the electrolytes and sugar? If you have the ability, you have not mentioned those.
Yeah.
Go back to the previous slide.
Sugars were around 185 month.
And sodium, potassium were normal.
I think the electrolytes are mentioned in the slides that are going to come by.
Okay,
But this ABG, there's something unusual about this ABG. What do you expect when you do ABG in a patient with severe preeclampsia or eclampsia patient? Normally, you have an eclamptic woman. You have done coming into the year. You have done ABG. What do you expect?
Lactic acidosis. Lactates will go up, sir.
Lactate may or may not go up, but you expect metabolic acidosis, right?
Acidosis.
It's very unusual to see a pH of 7.5. Normally, I have never seen a pH of 7.5 in pregnant. Although, so what is the physiological ABG of a pregnant woman? What is normal ABG of a pregnant woman? So you do ABG to a regular antenatal woman. What will you see in that ABG?
Respiratory alkalosis is normal in a pregnant lady, sir. PCO2 of 28 to 32 is accepted with pH of 7 point.
Yeah. So what values would you normally see? Just
pH, PCO2, bicarb, lactates, and electrolytes.
No. I mean the ranges. So in pregnant women, respiratory alkalosis is normal, right? So usually you see between 7.4 and 4.5. Okay,
Yes.
7.5 I have never seen. PCO2, what do you consider as normal PCO2 in a pregnant woman?
28 to 32.
28.
Yeah, 28 to 32. But so that's normal in pregnant women, right? Again, bicarb. What would you consider normal?
22 to 25, sir.
It will be even less. 18 to 22 is generally. So you see this in a normal antenatal woman, right? So I suspect that she might have got IV bicarb. I'm not sure, but this is not usual ABG that you would see in an eclamptic mother. You generally would expect to see metabolic acidosis with PCO2 of 25, bicarb of maybe 16 or 17. So that is a general picture. And pH of 7.32 or 3.3, something like that.
So one of the causes possible, maybe she had received steroids in the lab before pregnancy. Steroid is, and I'm not sure of which agent and how much dose. It's one of the causes of metabolic alkalosis. So that could be, I mean, it's not, doesn't exactly fit in the things, but if you consider something, as you say, Dr. Madapu, about, not very common pH fitting into the frame of pregnancy. She's postpartum, she has received steroids for probably mature to premature delivery. So that could be a contributory component. So Shabana and Vishnu, at this point, what are your issues or concerns in this patient at this point of time? What is the diagnosis? You have one predominant diagnosis, right? So what is the diagnosis?
Pregnancy-induced hypertension with the seizures, most probably eclampsia.
Most likely. Any other differential would you like to consider? Or you do not want to consider, I mean, whatever, it's either way. She had a delivery done was under which kind of anesthesia was given for delivery? LSCS. She had an LSCS, no, 2 days ago.
Yes, ma'am. They just
emergency.
wrote emergency LSCS type of anesthesia was not mentioned in that.
So you didn't find out? Was it anesthesia, general anesthesia, or it was regional anesthesia? Does it have anything to do? Can it have any implications in the current illness? You have treated that patient, right, I believe? So, was it general anesthesia or was it local anesthesia? I mean, regional anesthesia. She had born this baby as a result of infertility treatment, IVF, right?
Yes.
Precious pregnancy.
Yes.
So, what was given? I mean, you need to know at least the surgery has been performed. Okay. So, if regional, if I say spinal, Does it indicate anything? Could be spine. I mean, very rare though these days in good setups though, but meningitis. Is it possible? Because she had predominantly neurological symptoms. Of course, given her antenatal history and presentation, etc., it sounds very classic of eclampsia. But one of the closest diagnoses will be meningitis. Fever, temperature is normal though, as you say here, but it's one of the differentials. And general anesthesia also will have an implication, won't it, depending on what agents have been used and how was she optimized, if any workup has been done. Because if your first diagnosis is the eclampsia, she has a seizure now, it's a multi-organ syndrome, isn't it? So all organs, including mainly the cardiac and the renal one, also bear the brunt. So they might have an implication also in the performance. Now, immediately within 2 days, she has developed complications. What about this blood pressure? What do you think of the blood pressure? Are you happy with the blood pressure, or?
It's on higher side. 150/90 is not.
What about the saturation? She is 91% on room air postpartum. So what do you think? Is she hypoxic? She is hypoxic, right?
It's hypoxic.
Yeah. What could be the cause of hypoxia?
Possibility can be pulmonary edema and with history of seizures, aspiration can also be.
Yes. And what else? Pulmonary edema due to? What are the causes of pulmonary edema or hypoxia in a lady with preeclampsia or eclampsia?
Severe preeclampsia or pulmonary edema would be one component.
Is it pulmonary or extrapulmonary cause?
Pulmonary.
And what else can cause hypoxia?
Peripartum
cardiomyopathy.
Can be there, yes.
And postoperative atelectasis, which is this patient
if she was lying flat, I mean, she was not moving at all. That's an extreme morbid condition, if you think. And because you do not have any history about her, you do not have any reports of urine output, all those conditions you do not know as you sound. Right? She could be in a fluid. Could she be in fluid overloaded state?
Fluid overloaded state.
She could be. I mean, we don't know. You do not have adequate history from her. Right? So what would you do? Like proceed. Please proceed next year.
So basically, say it helps to talk to the referral doctor. So whoever is referring. So sometimes so that we can fill these gaps, right? So that will also help you in understanding better and treating the patient better. And once the patient is getting better, it also helps to call them back and give them tell them that how things are and give some feedback. Okay. So this looks like she had eclampsia after the delivery, right? So cesarean section was done at 6 p.m. and she had eclampsia at 1:30. And she came to Yashoda at what time?
Next day after second episode of seizure, sir. After 12 hours, she had one more episode of seizure. After that, she came at 5:30, 6 o'clock.
In the evening. So 1:30 a.m. she had eclampsia and she came to the hospital at 5:30 in the evening. And when was this? When did they start magnesium sulfate?
Immediately after first dose of first seizure, they started magnesium sulfate.
Then she should not be on 4 grams IV running by the time she comes to the hospital 12 hours after the first episode of fit, right?
Maybe during transportation.
Are you getting my question? I'm just trying to understand the scene. So for Dr. Sharmila's understanding, Nalgonda is like 2 hours from Hyderabad. So if they must to reach Yashoda at 5:30, they must have started somewhere around maybe 2:30 or 3-ish, right? And by that time she already had second eclampsia, and then she started. First episode of seizure was at 1:30 in the night. So that it looks like she had a prolonged period of time where she did not receive magnesium sulfate. From the history, that's what the sense I'm getting. So we don't know because again.
She had second episode at 1:30 p.m. sir, afternoon. After that, she has been referred here. With almost a 4 hours gap.
So let us
anyway, proceed.
General examination, patient moderately built, moderately nourished, no pallor, icterus, cyanosis, clubbing, and bilateral pedal edema, pitting type of pedal edema present. Systemic examination, CNS patient drowsy, arousable, obeying commands, GCS E3, V4, M6, and no focal neurological deficits. Moving all 4 limbs, bilateral deep tendon reflexes 3+, CVS S1, S2 heard. When we received her in ER, my crepitations, fine crepitations were present in ER. But when she was shifted to ICU, no creps were present at that time. Respiratory system, bilateral or NVBS heard. Per abdomen, soft scar tenderness present over incision site. And no organomegaly.
Right. Next.
A provisional diagnosis of pregnancy-induced hypertension with eclampsia, posterior reversible encephalopathy syndrome, cerebral sinus venous thrombosis, and HELP syndrome.
So the bottom 3 are your diagnosis or differential diagnosis?
Differential
diagnosis.
Okay.
So actually, the second and third are just they are as a consequence of your differential diagnosis, right? PAH with eclampsia, HELP. They can have as a consequence press or PSVT, right?
Yes.
They themselves are not a primary diagnosis.
Right. So how did you manage her? And how much you
Initially,
managed?
airway breathing and circulation should be taken care of, ma'am.
Mm-hmm.
GRBS, sorry.
Yeah, cool. Continue.
Airway breathing circulation should be managed, should be taken care of. And being a pregnant woman with a postpartum within 12 hours seizure disorder, but difficult airway is anticipated in case of if a patient is seizing.
So how will you manage? What treatment will you give and what investigations will you send?
For this patient, we have received her in ICU, ma'am. After receiving her baseline vitals, we have seen, and BP was around 140/90. She was drowsy, arousable. GRBS was 180 around, and we have started her on magnesium sulfate infusion also, ma'am. And we have started her on anti-epileptics. Levipil was given. Stat dose is given and followed by BD dose, 1 gram stat and 500 mg BD. Then we have ordered few investigations like routine CBP, serum electrolytes, RFT. We have also sent LDH D-dimer, and X-ray we have seen, ma'am, it is normal.
MRI
Why
was done.
LDH and D-dimer?
So,
There's nothing right and wrong. If you have a protocol, I just want to understand for others also who are listening who do not do this. Why LDH and D-dimer?
LDH as a part of a differential diagnosis to rule out HELP syndromes, whether any hemolysis going on.
Okay, and D-dimer? D-dimer, what do you want to look at? Anything else you can do to if you're looking for HELP syndrome for hemolysis? Can anything do simpler to look for hemolysis?
Peripheral smear also.
Yeah, we can do, right? Because LD is so non-specific. If it is, I mean, it can send and nevertheless, it's so non-specific. She had a surgery done also. She has, of course, a post-ictal state. She has a severe sympathetic responses there. I'm not sure if that's what is about her specificity and sensitivity to help you diagnose HELP syndrome for that matter. D-dimer similarly, I mean, you can also have it reserve as a second line investigation rather than saying it up front. It's not that necessary. And what else? X-ray you have done, right?
That's it.
Yeah. And?
MRI brain done.
MRI, would you like to do her? Did you do or you would like to do? She's, you say she's drowsy, arousable, obeying commands, like M6 is obeying commands.
Yes.
What about her, limb powers and responses? Did she have any focal deficit?
No focal neurological.
Why do you want to do an MRI brain?
Actually,
Hmm.
they have ordered MRI from the ER itself, ma'am. Since she was drowsy, she didn't receive any anti-sedative drugs. They have from ER, she has undergone MRI and she came to us.
She had already MRI was done for her. Okay, okay. But suppose MRI was not done. I mean, suppose if you're suspecting any intracranial lesions, what would be your quicker one compared to a lady who is requiring oxygen? She is not, I mean, that unstable though. What would be quick imaging if you consider to rule out CNS lesions?
CT brain can.
Quick CT brain screening. If you what you're suspecting, either an infarct or a bleed, right? So bleed will immediately at least show up. And in fact, if it is to develop, it will develop over a period of time. It may or may not show up, plus minus. But I would say in such acute situations, at least when the patient is drowsy and airway is patent, M6, so MRI probably could be avoided in those cases. Because what? Why? Why you tell me why MRI? This is very important points. Especially, I want the message for the peripheral centers, smaller centers, where it could be difficult. Why for this patient? They did it successfully in your center. You are a tertiary center. But why it is a risky procedure for this kind of patient from emergency to go for an MRI?
Because she might throw another fit or she might.
Yes, you are not secured the airway. You want, she's drowsy, she might just throw another seizure in that gallantry itself, right? So it's a life-threatening situation it becomes. So absolutely, if your purpose is to rule out any focal intracranial lesions, best is to go for a just quick screening, which will take not less than 5 minutes. And you are very much with the patients, right? So any smaller centers also can do that. But MRI, I would reserve it for subsequent if you have a difficulty in assessing the particular diagnosis. Suppose I have a scenario. Now this patient, she has come to your ICU. Now as soon as you receive her in the bed, now she is magnesium is going on, oxygen you have given, she throws another seizure. What would you like to do?
A bolus dose of magnesium sulfate 2 gram can be given.
It is bolus. Okay. Bolus you'll give 2 gram. And she is having tonic-clonic seizures going on with a magnesium drip already is hooked on from outside, as you said. What would you do?
Airway should be taken care of. Patient should be in a left lateral position with the
left lateral positions, yes. How would you take care of the airway? Immediately, what would you like to do? She's on some oxygen. So what would you do?
We will,
any other drug would you like to give? Magnesium will immediately abort the seizure like that? I mean,
we will give
you have to give some benzodiazepines to abort the seizure, isn't it? Some degree, whatever we have taken control of the airway, you have to give. Because magnesium, can you give like that? I mean, she's on a drip. You also do not know how much she has received from outside. And if you're giving a thing, you do not know if you're crossing the toxic dose or not. In magnesium is not given that way to abort seizures, right? You can give some titrated doses of benzodiazepines at this point of time. Now she becomes more obtended, of course, after you have given, say, lorazepam, you have given 4 milligrams. So 2 milligram, 2 liters of oxygen is not sufficient now. She is becoming desaturating further. How would you do?
What intubate her, ma'am? We will have a. We will intubate her. We'll first we'll.
We should anticipate a difficult airway and intubate her. First, we would like to pre-oxygenate her for 5 minutes with 100% oxygen with Bain circuit. And difficult airway
part should be ready, ma'am. Then we'll proceed with rapid sequence intubation. We will give fentanyl and rocuronium together with required pressure and intubate with a lesser number of ET tube. That's required.
So what are the causes of difficult airway in a pregnant lady? That to this lady who is eclamptic. Now she has come with seizures.
Progesterone-induced airway edema with short neck and large breasts.
Difficult laryngoscopy will be an issue, ma'am. And these patients will desaturate very rapidly because of high oxygen demand and less FRC. So we have to take care of, we have to pre-oxygenate well before attempting an laryngoscopy.
What is the effect of preeclampsia? Preeclampsia in this case on the airway?
Chances of aspiration.
Aspiration as such will come from gastric contents.
Airway edema will be there.
Airway edema plus what in terms of vascularity and friability?
Increased vascularity.
Vascularity, yes.
Bengal.
Yeah, they tend to, if you're like trying to,
Bleed more.
working hard to expose the epiglottis and the cords, you might end up trauma, and trivial traumas also tend to bleed in these cases. So you have to be gentle in these cases, and always better call for help in extra hand if it is after hours or something, right? So you'll intubate these patients. Then what would you do? Your magnesium is going on. What will you do? She's still showing seizures. You have given Levipral, you said. You have given Levetiracetam.
Yes, ma'am.
Yeah.
But still she is seizing.
We'll give lorazepam also, ma'am. If afterwards also she's continuing to throw seizure, then we will go for
Second line
Second line.
anti-epileptic drugs.
Which is?
Levipil for phenytoin,
Phenytoin.
fosphenytoin.
Levipral you have given already.
Yeah.
phenytoin, fosphenytoin.
How much will you give?
20 mg per kg is the usual recommended dose.
Right? How will you give that? So she is suppose now 70 kgs. So it comes around 1.4 grams. How will you give? These are practical situations, isn't it? We had a patient a year ago like this. That's why I'm asking. Also. How will you give?
We'll give it in 100 ml NS with slow IV.
Over a period of?
1 hour.
1 hour.
Why? So why we have to give it slow? No, why not push? Because she's seizing. I can give it fast. What can happen if you give phenytoin fast? You're giving first phenytoin. It's a more safer drug than compared to phenytoin, they say. But even then, it is given slow. Why? What are its adverse effects that were very off? How does phenytoin work as an anti-epileptic?
It potentiates GABA inhibitory action.
Is it? Okay, you have intubated this patient, right? You have given phenytoin, now seizure is controlled. What about the blood pressure? Blood pressure was in all this process, blood pressure is now reduced. I mean, it is kind of normalized. And GCS is obviously low now, you have sedated and all that. So you would like to do a CT. I mean, if you have already done, if you have not done any imaging, you would like to scan her brain to see for any complications. So now it comes all these things what you have written here about your differential diagnosis, if she is developing, if she has developed any acute lesion or not, right? Then next, what will you do? What is your plan next? Magnesium, how long would you like to go for, and what are the targets of magnesium? How will you monitor magnesium therapy?
I think go to the next slide you have mentioned. So there are a few things
Probably, I think,
that we have to.
can you tell about the magnesium? Yeah, most of the questions are coming in. Probably, as Madam asked regarding magnesium treatment, how do you proceed here? Dr. Vishnu or Shabana?
Dr. Magnesium, pitcher's regimen and Zuspan, both regimens can be used. Now we are using only Zuspan regimen, where 4 grams IV loading dose will be given, followed by 1 gram per hour infusion to be started. It should be continued over after 24 hours after the last seizure episode, with monitoring of deep tendon reflexes, respiratory rate, and urine output. And therapeutic levels, I would like to maintain between 5 to 8 levels, 4.2 to 8.4 is the recommended therapeutic levels. With
So how often do you send magnesium levels?
12th hour.
I mean, I think BD, I think 8 to 12 hours, I mean, 3 to 4 times you can send. I mean, 2 to 3 times a day, which will be 8 to 12 hours. Right? Right.
Why do you need to send serum magnesium sulfate levels?
Because patient, if she's on ventilator, sir, we will paralyze and sedate her. So we cannot elicit her deep tendon reflexes. Go and look for clinical.
So actually we have to look all pregnant patients little differently. than your routine other critical care patients who are coming in with seizures, right? So pregnant patients are slightly different. You can, so normally we rarely do serum magnesium levels. But when you look from critical care background, you tend to investigate more, right? So there are certain subtle differences. Why do you expect the serum magnesium level to go up? So you have, for let's say, let us think that you wanted to do serum magnesium level to see. The only reason why you would do serum magnesium level is to see if there is, if the serum magnesium is in therapeutic range or not, right? What else do you expect? So you got one level and you are giving 1 gram per hour. So do you really need to do so many times serum magnesium level? So actually the obstetric literature does not ask you to do serum magnesium levels so frequently. But from critical care background, you may be accustomed to doing serum magnesium so many times, so that's fine. So these are some subtle differences. I am giving a different perspective from a different background. So that's one. So usually you don't require to do, the only time when you repeat serum magnesium level is, so normally a patient has come in with eclampsia, has started magnesium sulfate, and she's fine. Her symptomatically she is better. Her headache has come down, and with antihypertensives, her pressures are under control. That's it. We are not going to investigate or do anything further. But if she throws a fit on or while on magnesium sulfate, then we do give 2 grams magnesium sulfate bolus. Okay. So and then so we have given, and then we may, or at that point we may or we may not do repeat serum magnesium level. Even if we get one level that is within therapeutic range, we leave it there. If you are continuing magnesium sulfate for more than 24 hours, okay, so that means you have given it for 24 hours, patient is still having headache, still the pressures are high, and clinically you feel that you may have to continue the magnesium sulfate for further. So usually this doesn't happen in postpartum cases, but in antenatal cases. So antenatal cases, patients come with high blood pressure and you're giving intercurrent magnesium sulfate. So that means you're trying to buy some time before she gets the steroid dose in for 48 hours, and then you probably sometimes you end up giving magnesium sulfate for more than 24 hours. So that's probably one time to see that. Then your worry is to see the level is not going into above the therapeutic range, or where you will see complications, right? Otherwise, normally we don't routinely do for obstetric patients magnesium sulfate so many times. So this is one perspective from an obstetric anesthesia background rather than critical care background. There are other subtle changes. So we have talked. So LDH. So normally you would think that LDH is non-specific. But for eclampsia, LDH is one of the diagnostic criteria. So you have to do LDH in all pregnant patients. So how do you define HELLP syndrome?
Hemolysis, elevated liver enzymes, and low platelet counts. Yes.
Okay. So there are two definitions to say that, okay, this patient is fitting into eclampsia criteria. You know those things?
Mississippi and Tennessee classifications.
Yeah. So what are those?
Mississippi is based on the platelet count, AST and LDH, sir. There are 3 classes, class 1, class 2, 3.
1, 2, 3. And
Mississippi is primarily based on platelet count, I think. So anyway,
Yes.
Whatever it is, forget the name, but can you elaborate those things?
platelet count less than 50,000 is class 1, with AST, ALT levels less than greater than 70, sir, and LDH greater than 600. Class 2 is platelet count between 50 lakh to 50,000 to 1 lakh, and class 3 is 1
Yes.
lakh to 1.5 lakh.
So I think so basically Mississippi is primarily based on platelet count. Okay, less than 50,000, 50,000 to 1 lakh, and 1 lakh to 1,50,000. The other criteria is HELLP syndrome should have three things: LDH more than 600,
Yes.
SGPT more than 70 or 80,
7.
and platelet count less than 1 lakh. If all three criteria hit, it is HELLP syndrome. If the 2 of the 3 hit, it is incomplete health syndrome.
Incomplete health.
Okay, so LDH is a necessary. Then D-dimers doesn't have much role. Then they are coming to imaging. So when does a eclamptic patient really require CT imaging or neuroimaging? In certain situations they do, but not all eclamptic women you would need to do neuroimaging. So let's say the patient has come, she has thrown hit, she has thrown a seizure, and the same patient, right? So our goal is to see whether there are any intracranial. Basically, what happens after a seizure? The commonest cause of death in HELP syndrome is HELP or severe preeclampsia. How do mothers die from preeclampsia? Through intracranial hemorrhage. Okay, they have intracranial hemorrhage from either high blood pressures or after a seizure. So that is one. So if they have some neurological signs, yes, we can quickly do an initial CT screen to rule out intracranial hemorrhage. Okay, that's appropriate. Otherwise, if you don't really suspect, if she has just thrown seizure and she's a little drowsy, that itself is not a straight away indication for CT brain, but that's fine. If you want to do it and rule it out, you have the facility, fine. What is more important is to get in that magnesium sulfate in as early as possible and get that blood pressure down as early as possible. These two are the most important things in management of preeclampsia. All other investigations are next. Those are not the first things. That is number 2, number 3, number 4. Okay. So neuroimaging, again, probably we would, or we may or may not have done. I mean, it is not necessary, but again, it's a clinical judgment. MRI, MRV. So the other thing is, any preeclamptic mother or an eclamptic mother after a seizure, you do MRI, MRV, they will most likely, almost majority of the times, they'll have Press syndrome. That is given. After eclampsia, you do MRI, MRV, very highly likely that they'll have Press syndrome. Okay, so it's there. I mean, it is that common actually in after eclampsia. So that's another thing. The imaging, when will you consider imaging in eclamptic women? So if there are any localizing signs,
focal
or you
deficit.
suspect this thing, then, or if the headache is not reducing, or if she keeps on throwing seizures, so you're giving adequate magnesium sulfate. Magnesium sulfate is in therapeutic range, still she is getting seizures. That is unusual, right? Then you have to do a neuroimaging. And which is the most choice? I mean, among the neuroimaging, what is the preferred neuroimaging that you would do at this point?
CT brain. If postpartum CT brain, if airways are not secured.
Forget about airway. So that's what I'm saying. The first goal is airway ABCs, magnesium sulfate, hypertension management. These are our first goals. Once we have done all these things, okay, the very fact that you are sending her to MRI, that means you have already taken care of ABCs, magnesium sulfate, and hypertension. Okay, there is no urgency to do MRI, MRV in eclamptic patients. So only if they are having repeated seizures when magnesium sulfate is in therapeutic range, then you have to suspect something else might have happened, or they have some localizing signs or neurological deficit. MRI plus MRV is the thing that you have to do, because you also want to see the venogram. If you don't do it, again, you will have to take her back and do it again to see if there is any thrombosis. So MRI plus MRV, if you do it in one shot, it will be done. And it's generally not an urgent thing that you have to do in the ER itself. Okay. Yeah, I think,
let's proceed to the next slide. Yeah.
Yeah. And one more thing about eclampsia management, generally, they are not usually seeing status epilepticus in eclampsia is again very rare. We can use lorazepam plus magnesium sulfate or benzodiazepine plus magnesium sulfate to initially calm the patient down. And sometimes what happens, they are very irritable, very irritable. You will have difficulty in putting in even an IV cannula. Again, the important thing to remember here is never rush through to an intubation. because we already know the incidence of difficult airway in an eclamptic mother is 1 in 8. There is very high chance that you will, especially in an ER setting, where the positioning, everything is not optimized, you don't have video laryngoscope in place, you may have difficulty in intubating. So don't rush intubating, secure the airway, maybe give her some 100% oxygen with the veins, and primary goal is to control the seizures with benzodiazepines plus magnesium sulfate. Once the patient is calm, or sometimes even you have to do propofol scoline and then take airway control, and then once everything is set in a controlled environment, intubate the patient. Never rush through intubation in an eclamptic mother. And yeah, so then usually what happens, if magnesium sulfate and benzodiazepines are enough, very rarely you will require the second line anti-epileptics. Yeah, so those are some smaller differences between your regular eclamptic patient or regular seizing patient versus a pregnant eclamptic mother. Carry on.
Investigation, complete blood picture. HB 12.9, packed cell volume 38, total leukocyte count 16,400 and platelets 1.35 lakh. LFT total bilirubin 1.1, SGPT 45, SGOT 57, GGT 41, alkaline phosphatase 110, protein 5 and albumin 2.6. Serum creatinine 0.8, blood urea nitrogen 10, blood urea is 23, sodium 134, potassium 3.8 and chloride 102. RBS is 83 and CUV pus cells occasional, RBC nil, glucose negative, protein 3+ and ketones negative.
Yeah, next.
The PT test 15.2, control 13.8, APTT test 27, control 29 and INR 1.9. Serum uric acid 9.6, serum calcium 8.6 and serum magnesium is 3.8. D-dimer 2317. Chest X-ray is normal. ECG sinus tachycardia. 2D echo is normal. Good LV function. No regional motion abnormality. No RARV dilatation and IVC collapse.
So serum magnesium is 3.8. This is at admission or later on?
ICU, sir.
During admissions.
During admission.
These were sent in ER.
It was sent in ER. Okay. Let's say I think you have sent another set of serum magnesium also.
Yeah.
Carry on.
Next.
So 3.8 is basically below. It's not in therapeutic range. Yeah. I'm assuming
MRI.
it is milli-equivalent.
MRI with MRV is done. Multifocal cortical edema with flare hyperintensity is noted involving bilateral frontoparietal temporo-occipital lobes, including bilateral capsuloganglionic region and splenium of corpus callosum, likely posterior reversible encephalopathy syndrome with small calcified granuloma in left temporal lobe. MRV is normal, sir. Both were done. Neurology opinion taken and advised injection Levitra setup 1 gram IV 12th hourly. Day 1, postoperative day 1. Patient was drowsy, arousable, GCS E3, V4, M6, bilateral pupils normal size reacting to light, temperature 98 degrees Fahrenheit, pulse rate 110 per minute, regular rhythm, blood pressure 160 by 90 millimeters of mercury, GRBS 96, SpO2 91%. This on receiving SpO2 91% room air and 99% on 2 liters of O2, nasoprons and respiratory rate 20 cycles per minute. CNS deep tendon reflexes 3+, right radial arterial line inserted and secured, Foley is inserted. Sure, patient was started on injection magnesium sulfate 1 gram per hour, injection Levipil, Levetiracetam 1 gram IV 12th hourly, injection pantoprazole 40 mg IV once daily, injection Levitelol 5 mg IV stat given, Nifedipine 20 mg per oral 8th hourly given. Started and the injection paracetamol 1 gram 8th hourly. Sure, started.
Anything else? No antibiotics?
Day 1.
No, I'm not asking. I'm whatever happened. It's nice to see if you have not considered antibiotic. It's a very brave gesture. And I just want to know what was done. I mean, was she was had a TLC count of 16,000. It could be just a stress response very much. But it's very rare to see not to have any antibiotics on board. on day 1, isn't it? Okay, so she was not given any antibiotic on day.
Didn't start any.
Okay.
No further day 1, day 2, ma'am. No further seizure episodes. BP recordings consistently below 140/90. Urine output 50 to 60 ml per hour maintaining. Deep renal reflexes 2+. Respiratory rate 16 cycles per minute. SpO2 98% on 2 liters of oxygen. Serum magnesium levels after 12 hours 5.3 and after 24 hours 5.8. And GCS 15/15. No bleeding PV and no fever. X noted.
Next.
GCS 14 headache, GCS 15 headache subsided, pulse rate 110 per minute, BP 130/80, SpO2 96% on room air. No further seizure episodes for last 24 hours. 24 hours magnesium infusion completed at 9 p.m. Urine output maintaining 80 to 90 ml per hour. And CBP HP 13.3, TLC total leukocyte count 13,300 and platelets of 1.38. Sodium 133, potassium 4.3 and chloride 102. Serum magnesium 5.8. Oral feeding.
What is the therapeutic range of serum magnesium?
4.2 to 8.4.
Milligrams or milligrams?
Milligrams.
This is milligrams or milliequivalent?
Milligrams.
Milligrams.
It is 4.8 to 8 point something. What you said? 8.4
4.2 to 8.4.
milligram percent.
Yeah.
5 to 9 milligrams is roughly the therapeutic range. Generally, you will tend to see signs of magnesium toxicity if the level of magnesium is above 10. If it is milliequivalent, it is 4 to 7.
You can tell at different levels what toxicity features will be there, Dr. Vishnu and
Yeah, so you have to be careful while you say milliequivalent or milligram percent, because there is usually confusion. That's
Milligram percent. Above 8, deep renal 4.2 to 8.4 is normal therapeutic range, and above 8 milligram percentage, deep renal reflexes will be lost. Above 12.
how will you treat magnesium toxicity?
We'll stop the agent and we'll give calcium gluconate.
How much?
Well, calcium gluconate is not advised because a seizure threshold will be low. So if it is magnesium toxicity is there, dialysis is the option, ma'am. Hemodialysis.
Direct dialysis. You're too aggressive.
Toxicity.
too aggressive.
Too aggressive direct dialysis. What did you do? Nowadays, I have not seen magnesium toxicity for long. But
calcium gluconate is the first choice.
Yes, you can give.
1 gram calcium gluconate
can be given.
You can give, right? You do not go for dialysis straight, especially in the absence of other organ dysfunctions. So now it is a happy ending as we see. Read your slide. So is that last or you have anything else?
One
more.
GCS 15, vitals are maintaining, no headache or further seizure episodes.
And this is all without any antibiotic. Your TLC count has come down. So I'm really, happily surprised that even after 2 days of cesarean section, she has not been any antibiotic from the previous center. And here also it did not do. And well done. And what about what about lactation separation? This is very commonly asked for ladies who have delivered and baby is live. Is it necessary? And if you know, how do you do? Or is it not necessary?
It's necessary, ma'am.
How do you do that?
So this baby was alive or dead?
Alive, sir. Sure. Baby was admitted in outside a neonatal other hospital. Sure. Lactation suppression is necessary, ma'am.
So right from this case, from the beginning, so when just going back to the first history, when she was 31 weeks and few days and she had diffuse headache and she was not feeling well, some pain, abdomen, etc. Then what do you think would have been done differently, going retrospective analysis? And it's an IVF year.
She was supposed to be admitted and started on antihypertensives with close monitoring of
Yes. So these patients
serious
definitely qualifies for safe confinement for treatment and monitoring. And of course, suppose she was now admitted with you. These cases actually are very common in any of these critical care exams, be it IDCCM, CTCCM, or DNB critical care or DM critical care, because very scenario is common in our country still. So if she was now admitted on say 32 weeks now, 31 days, few days, I tell
Go back to the first slide.
how do you treat her? And I mean, apart from blood pressure control, what are the agents you can use for blood pressure control in that patient? And suppose she had 160, 100, or you said something, or 9.
160, 100.
So what antihypertensive agents will you give? How will you prepare for baby delivery?
Ideally, arterial line should be inserted and invasive blood pressure monitoring should be.
Not necessary. If she is at 32 age, she could be, I mean, she is conscious, I mean, she has not any organ dysfunctions or decompensation. She can be monitored in an SDU level or in a room also, in the ward also. But what will be your age? What agents can you use to lower her blood pressure?
Labetalol, oral and IV can be tried. Oral, if a patient is.
And what are the agents? What are the?
She's 31-year-old. Let's say she is come to you instead of going to that nursing home, okay, with complaints of headache and blood pressure of 160/100. Okay, she comes to the ER or to you in the ICU with headache, blurring of vision, pressures of 160/100. How are you going to treat her? What will be your plan? Forget about this case. So this lady ended up with stress syndrome and coming to the Yashoda. Could something have been done better so that all this could have been avoided?
Yes.
IV antihypertensive should be started, sir, because she is having blood.
What IV antihypertensive do you have to start? What is your first choice, second choice, third choice?
Labetalol is the initial choice. Regularly we use labetalol with
okay. Dosage?
Dosage 5 to 20 mg IV bolus will be given, and every 10 minutes, if BP is not under control, doubling dose of 20, 40, 80 can be tried up to a maximum of 300 milligrams cumulative dose. Even if it is not under control, second agent should be added, like hydralazine or nifedipine or nicardine.
Hydralazine dose?
5 mg to start with, sir. We can give up to 20 mg. It can be given IV or IM.
5 mg every 20 minutes.
Yeah, which is the other drug? So all these three comes under first line. Labetalol, hydralazine, and
nifedipine or
nicardine.
Nifedipine.
Oral nifedipine. So not cardiac retard or slow release nifedipine. It's regular nifedipine. What is the dosage?
10 mg immediate release, not extended release. 10 mg 8th hour.
How do you give it? Swallow or under the tongue?
Sorry, under the tongue, sir.
Immediate release.
What happens if you give under the tongue?
The precipitous fall in blood pressure, one might be the complication. So
it should never be given under the tongue. It is swallow, not under the tongue. Okay, you can crash the blood pressure. Okay, so swallowing, not sublingual nifedipine. So that is for emergency, acute management of hypertension, right? So
how will you prepare the baby? I mean, fetus, suppose you're planning to deliver 34 weeks.
We will give a steroid dose for a lung maturity, ma'am, if it is less than 34 weeks period of gestation, or if there is any imminent organ dysfunction, then we have to straight away plan for delivery.
So have a multidisciplinary approach with a neonatologist and obstetrician and your critical care team, right? So obstetric cases are very common, as I said, and they are very highly scoring also, because there are standard questions that we have been presenting and we have been discussing. They might give you some permutation combination of scenarios, like I made it seizing after when you're receiving in the critical care. As Dr. Madapu said, like this patient probably even first came at all in a serious condition that you need to give IV antihypertensive agents. So those permutation combinations would be there. But this is, if the case is there in the unit, it will be definitely asked in physical exams like DM or DNB or in IDCCM if this case is scenario is present. What are the complications, multi-organ complications of preeclampsia, or severe preeclampsia or eclampsia like this?
Cerebral edema, pulmonary edema, renal insufficiency.
And it's a multi-organ syndrome. When
Multi-organ.
you pick up, you'll have a problem.
Coagulopathy.
Hepatocellular necrosis and hepatic subcapsular hematoma.
And
So one thing to remember in complications is, it is extremely rare again to have frank coagulopathy, INR going more than 2 in a pure HELP syndrome or preeclampsia related complication. Thrombocytopenia is more common. Platelets can fall to less than 50,000 or 30,000, sometimes even 18,000, something like that. But to have INR to go beyond 2 is not common. That's something to remember and to differentiate it from AFLP or other clinical syndromes which present similarly.
right, I think you've done well. And these are the cases. This is the case exam that we usually get in exam, probably a bit more complicated than this. They'll be having some area issues. They'll ask you about how you intubate. That's why I asked you. And suppose how they're taken to theater after the baby, then what would you do? Imaging, drugs, and then of course all other organ management if they are proceeding to, for that matter. And for platelet threshold for giving regional anesthesia. What will be your platelet count?
75,000 is the cutoff, ma'am. If it is below 75, we cannot give regional anesthesia for this patient.
75, I heard a new number. I mean, so any range you said, suppose it is 74,500, then? For cesarean, how much they need? Obstetricians?
For cesarean, they need
Any surgery for that matter, any abdominal open surgery.
they will need
What is
minimum.
the platelet count threshold before you decide giving a transfusion?
For platelet transfusion, sir.
At what threshold what is the threshold for platelet transfusion?
For minor procedures or minor surgeries, 50,000 is the threshold, sir. If it is major surgeries like abdominal neurosurgeries, 1 lakh will be the.
So what is obstetric cesarean section? Is it minor or major? Moderate.
That is. How much should you do? It is 50, 75 or 1 lakh. You have ABC. Audience can answer. Can you see QA, Dr. Kaladhar?
Yeah, I can see.
Please see. Audience is open. A is 50,000. B is 75,000. C is 1 lakh for cesarean section. Please type in
So
your
this
answers.
is the surgical threshold.
Surgical. For cesarean section. For cesarean section, I asked.
1,80,000 B. Yeah, these are the different answers we are getting. B.
What is more? You can see
75,000.
actually. 1,80,000. A. B, I said what? 80,000. Yeah, most are B. 75.
75, 50, 50. A. Mixed answers. Yeah, 50 and 80,000 are equal votes basically.
So for any abdominal open surgery, it is 50,000 for surgical indication to transfuse the platelet. For spinal anesthesia, what are the things that are important? One is platelet count. The other one is coagulation profile. So as I said, in HELP syndrome, usually it is extremely rare for INR to be more than 2. Usually you may have 1.5, 1.7 maximum, but platelet counts can fall. So in absence of coagulopathy, platelet count above 70,000, you can give spinal anesthesia. But again, it depends upon the fall, how labile the platelets are, how rapid the fall is, how difficult the airway is. Do you have any additional equipment and help to manage a difficult airway? So it is pros and cons. So let's say it's an obese patient with difficult airway, middle of the night, help is away, you don't have any special airway equipment, platelet counts are 72,000 or 69,000, there is no coagulopathy. What would you do? What is the safest option for anesthesia? Spinal, right? So what I usually do is, sometimes the lab LDH can be like 900, liver enzymes can be in thousands, difficult airway, middle of the night, okay, but INR maybe 1.7. Will you go for general anesthesia? Usually not required. Okay, the complications of general anesthesia and failed intubation are much higher than the incidence of neuraxial hematoma. So if you want to take a chance with spinal. Okay, it's extremely unlikely to have a neuraxial hematoma. What you can do is take some blood in red top or a glass bottle and check the bedside clotting time. If the blood clots in 10 minutes, you are good to go. Usually they don't bleed intra-op also. Okay. The other thing to look out is how fast the platelets are falling. Usually, if it's in antenatally, if you are planning surgery, you need to have a platelet count that is within 6 hours. Sometimes, if the health syndrome is progressing rapidly, afternoon the platelet counts will be 130,000, LDH will be like 600 or 400. After and by another 6 hours by night, LDH can go up to thousands and platelets can fall 80,000 or 60,000 or 40,000 water. So the fall can be extremely rapid. In such, if the fall is very, very rapid and significant, then again you have to think about it doing this. But in general, if you are in a caught in a difficult situation, take chances with spinal than airway. Next, lactation suppression usually we don't do. So I can understand the situation because the mother is at a different place and the baby is a different place. If the baby is alive or in NICU, the best thing to do is to express the milk and then send the milk to the baby, so that you keep the lactation running. Suppressing the lactation, that means if once the baby and mother are out of NICU and hospital, you're depriving the baby of breast milk, and that will have its consequences, right? Only if there is IUFD or the baby has died, then lactation suppression comes into play. Usually you give thiamine for lactation suppression, rarely bromocriptine. Otherwise, generally you don't. You just express the milk and send the milk to the baby, or pump and dump.
Yeah, it can be done, right? It's not necessary that you need to suppress it unless the patient mother is already on ventilator, sedation, and all multi-organ dysfunctions, etc. So I think this happy ending. But you in exams, real scenario, I mean exam scenarios, as I said, they twisted to extract from you about your how to manage the airways, coagulation abnormalities, anesthesia for delivery of the baby, etc. And in such patients who are presenting with eclampsia or severe preeclampsia, for that matter, always along with the initial blood group, always mention about blood grouping also, so that you never know. I mean, it could be a positive, negative, whatever group, so that you sounds more complete. You have mentioned everything in detail, but blood grouping always a common thing that we also already do. Right.
So if you were to give platelets, which is your choice, RDPs versus SDP? So in a big hospital, you will have access to both, right? So what would be your choice of platelet transfusion?
We prefer SDPs.
So as much as possible, stick to SGP because there's risk of infection is much higher, right, with platelet transfusion. Another scenario is if she's a some negative mother. You know, platelets are pooled platelets, and that can cause again IgG. The antibody generation, right? So
Alright,
if
sir.
she's a negative mother, she needs a SDP transfusion. She should get only SDP. As far in an emergency, if you have no other choice, that's a different story. But as much as possible, stick to SDP. Then a couple of things about Press syndrome. How would you define Press syndrome? What is it?
It is a hypertensive encephalopathy, sir. It is a neurotoxic state in which it is secondary to loss of auto regulation in the posterior circulation to the acute changes in the blood pressure.
So it's basically a clinical diagnosis. It's not exactly encephalopathy. It's not that far off, but it can go there. Okay. So headache, altered sensorium, blurring of vision. Okay. And in MRI, you see that typical Press syndrome features. Then, so it's basically clinical and radiological diagnosis. And how do you treat Press syndrome? What is the most important thing while treating Press syndrome?
Hypertension.
Because if you don't manage Press syndrome properly, it can have fatal consequences, right?
Hypertension control.
Yes. So remove the source that is causing Press. That is extremely important. So good control of hypertension and removing the source is most important in managing Press syndrome. So what are other conditions where you will see Press syndrome apart from preeclampsia, eclampsia, hypertension?
Dehydrated states. Patient is dehydrated.
What state?
Dehydration, sir.
I'm not sure. Any other causes that will cause Press syndrome?
Autoimmune conditions.
Malignancy, then autoimmune disorders, then what else?
Immunosuppression, most common.
Yeah, immunosuppression, basically malignancy, transplantation, immunosuppression, toxins. Okay, so these are more difficult to treat. In preeclampsia, if there is a Press syndrome, your primary goal is to control the blood pressure and she'll come out of it. But in certain conditions, you are unable to treat immunosuppression related Press or malignancy, so or other things. So they will proceed to encephalopathy and death. Okay, in preeclampsia, if you don't control hypertension, it can proceed. So that's most important. And finally, any concluding?
Dr. Kaladhar, you want to add anything?
Yeah, probably one question, ma'am. Did you see in your clinical practice anytime the patient who were pregnancy-induced hypertension and eclampsia, and you think these patients are having some TTP-HUS overlap syndrome, where you might have to consider therapeutic plasma exchange because it may be lifesaver, especially in the context of TTP. So the dilemma comes most of the time. Some cases here and there, rare cases do present with that. So how do you differentiate and err on the side of providing TTP in these patients?
Yeah, I didn't have TTPs, but we had a case years ago. She was a staff nurse herself. She had delivered outside and come to us with multi-organ problems. And when she recovered, actually, she had persistent renal failure. And she used to, have urine output, but then urea creatinine will rapidly keep rising. And then it's a diagnosis of exclusion, because with this eclampsia with multi-organ dysfunctions, then as you said, those are overlapping zones of either TTP and HUS. Only differentiating point between TTP and HUS will be TTP will have predominant neurological versus HUS will have a predominant renal involvement. And it did persist. Like in her case, renal failure did persist. Urea creatinine every 36 to 48 hours would go very high. And those are the cases we actually had to go for plasma exchange. And we also gave steroids. I don't know right and wrong, but we gave, and she did improve and she completely normalized in her follow-up. But always remember, because this is a very straightforward case, and as we ask you what this and that will be very straightforward. But having said that, there are cases which come to us referred from peripheries. They'll have some degree of infections, either as a case of if they have composed delivery, if it is vaginal delivery, then there could be written POCs. There could be some degree of sepsis either from the POC itself or for urosepsis. And also tropical fevers are not to be forgotten. Or secondarily, if after cesarean also, they'll have some kind of infections if it is not in the best conditions. So those cases, that's why we're asking about antibiotics. It's a good case. I mean, she was always hemodynamically stable. She never had any organ issues.
Yeah.
But some patients will come with organ failures, like they'll require supports, ventilator, they'll be require vasopressors, more of blood transfusions due to even mild or moderate derangement of coagulations. So those cases you have to transfuse. They won't be that straightforward. So what the principle we emphasize in the practice of critical care is, having one diagnosis, it's not necessary. You can have a working diagnosis and then a couple of differential diagnosis. So try to work on those things parallelly while you're resuscitating, while you're treating the main ailment, and resuscitate those patients, because the maintenance of this organ functions will be necessary when her primary pathology starts resolving and she is trying to come out. If these organs are not supported from the presentation itself, then they'll have implications, and consequentially it becomes at the end. So I would say keep a broad range of diagnosis in your mind. This is a very straightforward case as you presented. You write that you should investigate these patients for also coagulation abnormalities like D-dimer. I said there is nothing right and wrong. Depending on your affordability, depending on your infrastructure, you can send a little bit of extra. I know sometimes it becomes a bit more extra, but again, there's nothing right and wrong in clinical science, and especially.
So again, D-dimer in pregnancy is elevated. Generally, it has very little clinical value in pregnant patients. So this is again a different perspective from pregnancy point of view.
Exactly. So, and
you don't need to. Usually, we never send D-dimer.
Cesarean done
because
also.
it is expected to be elevated.
So what about any quantitative elevation as compared to see? There are numbers like, what do you think about, suppose it is elevated more than 5,000 or 10,000? Does that give any clinical relevance as compared to the absolute, I mean to say, absolute value of D-dimer? Because we had seen, especially in the COVID context, where the D-dimers were giving a specific clue, especially elevated more than 5,000, 10,000 procoagulant state, they developed a pulmonary thromboembolism kind of situation. But of course, in the pregnant ladies, most of the times we are worried about DIC and all, where we generally look at D-dimer. What do you think in that context, Dr. Manokanth?
So again, so if the clinical picture is telling you HELP syndrome or eclampsia, then it is very unlikely that D-dimer will be at that level. So there will be some other something else in the clinical picture, some other viral sepsis or some other sepsis that might cause the D-dimer to go up. But a straightforward, so it is very common actually. The thing is, we tend to overdiagnose obstetric patients and undertreat. Both happen simultaneously. We overdiagnose them and undertreat them, thinking because we are going on a different path. With so much of critical care patients that people see in critical care wards, when a simple eclampsia or simple HELP syndrome comes in, we tend to overcomplicate it and then miss the basic treatment of managing hypertension, delivering on time, and then postpartum stabilization. So most of this, the beauty about pregnancy is, if they become sick, usually you have to control the hypertension, give magnesium sulfate in time, and deliver them quickly, monitor them for 48 hours, and then they tend to improve.
So less is more is the concept.
Yeah, doing less, delivering early, and thinking straight will be helpful. So usually, rare diagnosis is intracranial. So sometimes seizures can be because of eclampsia, or it can be because of some intracranial tumor or whatever. But you have to see the clinical picture, clinical history. If it is suggesting straightforward eclampsia, assume that it is a straightforward eclampsia and focus on giving magnesium sulfate early, treating hypertension, delivering the baby, and taking care of the mother. She will recover. If there are any unusual signs, like after delivery she's having fits, or so the other important thing is differentiating between TTS, HUP, and HELP syndrome and AFLP. So AFLP and HELP syndrome, you deliver the mother, you expect the mother to improve in 48 hours. TTS, HUP, she won't improve. But clinically, it is almost impossible to differentiate TTS, HUP, AFLP, and HELP in certain all four can overlap and can be difficult to manage. But the first thing we have to think is not TTP, TTS, HUP. So I have seen places where they have gone, instead of just delivering the mother, she would have recovered. Instead, they thought about TTS, HUP and kept on giving plasma pheresis, and things went out of hand. Okay. So Adam TS13 will help you in differentiating microangiopathic syndrome versus this thing. Yeah, and which is like TTS, HUP and this thing. So basically, if the picture is confusing, to err on delivering the mother, and then initially you treat her as HELP syndrome or AFLP. If there is no improvement, usually first 48 hours, it is difficult to differentiate. Okay. They tend to deteriorate a little bit in the first 48 hours. Then they start to improve. You expect improvement within 48 to 72 hours. If the mother is not improving in 48 to 72 hours, then you have to think about HUS, TTP, send Adam TS13, look at the peripheral smear if there are any cystocytes. And then you think about initiating plasma pheresis. But initially, control hypertension, give magnesium sulfate appropriately, deliver the mother, and then sometimes they can have a acute kidney injury in preeclampsia, and sometimes initially they may require dialysis for a while. So those are the first line. If things are not getting better, then you have to think about other things.
Yeah, I think persistent, as you said, beyond maybe 48 hours and 72 hours, the patient started to deteriorate.
Yeah. So you expect improvement, but it's not happening, then that is unusual.
Yeah, very, very, very unusual. Yeah, as you said, it's most of the times the first line management, whatever you said, is the key principles. Other than that, these things are very rare, of course. Yeah. So I think
one has to be guided by the clinical scenarios as it goes.
Yeah.
In for coagulopathy, fibrinogen is very important. It's not D-dimer. So fibrinogen, again, you expect the fibrinogen to be above 400 in pregnant patient.
Yes.
If it is below in coagulopathy, like let's say abruption, massive abruption, they tend to go into coagulopathy and also cortical necrosis, and may have permanent kidney damage requiring transplant.
Yeah.
So again, those things, fibrinogen levels. So you have to quickly correct fibrinogen. If possible, if you have fibrinogen concentrate, just give 2 to 3 grams fibrinogen concentrate to arrest that coagulopathy. So fibrinogen, keeping fibrinogen above 200 to 250 is essential. So fibrinogen is more important than D-dimers.
Yeah, understood. Yeah. So anyway, I think it was a nice case presentation, Dr. Vishnu and Dr. Shabana. Thank you. And I thank Dr. Manokanth and Dr. Sharmili ma'am for sharing your practical insight. Actually, today, almost near to 120 people logged in to view the webinar. It's been a bit highest recently. So thank you very much. So we'll be in touch. Any final
There's a question on Adam TS13. Please clarify. So basically, it's Adam TS13 is a compound that binds 1 milliband factor to the platelet, I believe, right? So it cleaves the 1 milliband factor. So when there is Adam TS, so what happens in microangiopathic syndromes? You'll see the Adam TS13 levels rise because there is a problem in that cleaving, and there is coagulopathy that's happening. I mean, small microthrombi that are forming.
Yeah. Basically, if it goes down, generally 1 milliband factor and platelets will form multimers, which will form the thrombi, and then they occlude the microcirculation of different organs, causing right from neurological manifestation to all other dysfunctions, even pulmonary circulation, cardiac, everywhere. So they'll end up, most of the times they present with neurological manifestations. And of course, because of the platelet and 1 milliband factor multimers, the RBCs traverse through that, because of which they get destroyed, and which will be shown as cystocytes in peripheral smear. So this is an urgency, and of course, medical emergency, I can say. Without plasma exchange, 90% of the mortality will be there. It is not recognized early. That is the reason most of the times. So we consider that possible diagnosis as early as, And I think
Adam 130, I mean Adam 13 as mentioned. Actually, it is, I mean, of course, it has a role if you have, but most of the places, again, it will not be infrastructure won't be available to get it done. So when in doubt, of course, send it. But the clinical scenario is very important. I agree with Dr. Sasi that it is important. On the basis of clinical scenario, you have to consider those important differentials, because most of the times it is very unlikely that you will know one thing, especially when this patient is going on to develop MODSs. So you have to, on the basis of your clinical strength and assessment, you have to strengthen. Because I remember I was sent for that patient, it was probably 5 or 6 days before he got it. So it's not possible always, but keep in mind, of course, it comes one of those MCQs and can be asked as well. I think it has been very extensive discussions. Thank you, Dr. Sashi and team for arranging this kind of webinars, and Dr. Manokanth for very insightful discussions.
Thank you.
Candidates, best wishes for your future.
Thank you.
It's been a pleasure to be on this panel. Thank you, Kaladhar and Yashoda team for having me here tonight.
Yeah, thank you.
Thank you, Dr. Sharmili.
Thank you. Good night. Yeah. Okay.